Welcome everyone. Tonight we're just going to do a really quick recap on best practice for treating concussion, um, aimed at GPs, but we've got a couple of other healthcare professionals here. Um, and how do I? There we go. Okay. So SORCs for, as I said, GPs or other healthcare practitioners. The aim being to obviously we for people seeing concussion patients to get faster recoveries, clearer understanding of management and return to activity, and where and when to refer for to get faster improvement because as well, actually, I'll stay to the slides. To be better prepared for these patients who are in saying, I've got a concussion, what do I do now? And I'm not recovering from concussion. It's been weeks or even months or even potentially years. What else can I do? Because the research in the concussion space has evolved tremendously in the last 10 years. If you watch AFL, you'll see that there's been drastic changes in the way concussions have been handled in the last few years, and we'll get to that in a sec. But just quickly, who am I? I'm an osteopath. I graduated in 1998, but I've got a bit of special interest in head-related stuff, BPP, V management. I've done the Complete Concussions training program, which is a very extensive it's actually a Canadian-based concussion training program, and so a registered provider with them. And we run a lot of our bread and butter is basically came from treating headaches and migraines for many years, and then we expanded into the other topics. So for the people in the area, we're just on 324 Queen's Parade. If you recognize the strip of shops, we've got the Baker's Delight on the corner, and this is us just down here, 3 doors down in the Neil shops there. Alrighty, and that's basically what we just already said. Alrighty, so I tried to make it a little bit sort of, clinically relevant in terms of what we'd see in terms of what you would see in terms of people coming in. So I've got this lady here, and she's saying I had a fall off my bike, and I think I blacked out for a second when I hit the ground, but I don't think I had a concussion because I was okay afterwards. I was pretty good. And we get this all the time. And diagnosis of concussion is that you just need a mechanism of injury and either one clinical sign, and that can be loss of consciousness, amnesia, disorientation. So if someone comes in and they say, I fell and I hit my head and I kind of just, blacked out for a second, or couldn't remember what was happening for a second, or I was really disorientated, confused afterwards. And in the next sentence they say, yeah, but I don't think I was concussed. Up to you how you want to handle that, but basically in your head you can say yes you were, because concussion it's pretty simple. If you have a mechanism of injury and just one sign like that, they have a concussion. Alternatively, the official definition is if they have two symptoms as opposed to signs. Signs is something that you can diagnose as opposed to a symptom, which is something they are subjectively complaining of. If they've got headache, dizziness, nausea, visual disturbance, plus a clinical finding, which could be, memory loss, or there's different tests you can do, just, getting people to move their heads and seeing if it elicits symptoms, then you can diagnose it off symptoms and the one clinical examination. But the number of times that someone will come in there and they'll just give you a mechanism of injury and a clinical sign, it's pretty common. So a lot of the time it's self-diagnosed, but it's good to just sort of have that definition in the back of your mind. So take home, so you only need one mechanism of injury and a sign for it to be a concussion. So I've just thrown in there, I mean, this is aimed at GPs, so I'm not going to, tell you about red flags because, that's, as far as I'm concerned, this is your bread and butter. Make sure they haven't cracked their skull, or they've got a severe brain injury, which is deteriorating subarachnoid hemorrhage, etc. So I just put that in there just as ticking the box to remember that if someone says I've had a concussion, just make sure you tick the red flags off. But anyway, back on to more recent changes. So this guy said, coming, he said, I had a concussion. Does that mean my brain is bruised from my brain hitting the inside of my skull? And I went to uni a long time ago, but I've got a vague recollection that we were taught this. There's a coup contra coup thing which they don't sort of talk about so much anymore. It's the brain bouncing around and it hits the skull and we get a contusion on the front of the skull and it bounces back. And I think it may still be relevant in severe head injuries where there is bleeding and stuff in the head. But in answer to this gentleman's question, no. Go back to the question. Does my brain get bruised from hitting my skull in my concussion? No, it does not. The brain does not get a contusion from hitting the skull. If we take an imaging for a concussion, it is clear. It is clear that there is no bleeding shown. There is nothing. So concussion is a functional disturbance of the brain. So I'll just say that again because it probably took me a while to get my head around this as well. Concussion is a functional disturbance of the brain. There is no, as far as we know, there is no damage to the brain in a concussion. It is purely a functional disturbance. So in a little bit more detail, it initiates a neurometabolic cascade. So let's have a look at that in a little bit more detail to see what that means. All right, so concussion mechanism, we have an acceleration, deceleration of the brain, and so we have a shearing of the axon. So if we think of the brain as being like a jelly, like in that little picture there, we have gray matter and we have white matter, and the gray matter is a little bit heavier than the white matter. And so if we have a rapid acceleration, deceleration, we can get a shearing of where the white matter joins the gray matter, and the other places where the corpus callosum is a really common place for the shearing to take place for the same reason. So we've got dense brain versus less dense brain. So when we get the concussion, we can get a shearing of the axons, not necessarily a tearing or that we are aware of at this point in time, but it's purely a shearing. Now, what does that do? It tricks the brain cells into firing. So they're not damaged. They're just getting tricked. They're just getting tricked into firing. So let's have a look. So we have a neuron and we have a concussion. And so we have a shearing across this axon here. And what that does is we've got little, I'm just going to use the word holes. We've got little holes in the axon. And if we shear it, the holes get bigger and it allows potassium to come out, calcium to come in, which if you remember your physiology is exactly what happens when an action potential comes through a nerve and we have normal firing with the nerve. So basically, when we shear the nerve, it imitates an action potential, and it's this storm of electrical current which goes from one cell and then it gets passed on to the next and to the next. And we end up with what we've got here. It's called cortical spreading depression, but it's basically all this cascade of firing neurons goes across the brain due to this being tricked into firing. And a couple of interesting points. We get glutamate released at the cell membrane here, and I'm saying this for a reason. And in the same way that we have potassium coming out and calcium coming in these other cells, we have this calcium flood because glutamate tends to adhere to the cell receptors here, and it kind of opens the channels and allows way too much calcium to come into the cell. And once again, there's a reason I'm saying this. I'm not just giving you pointless physiology. And thanks to ChatGPT, I was able to come up with a picture of a sad mitochondria, because that's basically what we've ended up with, because we have all of this calcium flooding into the cell. The mitochondria gets overwhelmed. And why is it sad? Because it's got way too much calcium inside the cell, which impairs the function. And so what does that mean? Is that it cannot do its normal oxidative metabolism, and so it has to do anaerobic metabolism, which requires more oxygen, which gives you an oxygen deficit in this time where you've got all this calcium coming in, so you need lots of energy to clear this calcium out, and you've got to switch to an anaerobic metabolism, which is 5 times less effective. And so basically, we have this huge energy deficit in the brain, which is the bottom line that we're getting to with all of this. But I just thought I'd give you the whole story because I think it helps understand it. So here's a graph, and just going to draw this. So this is what we draw for every concussion patient who comes in. Get the right pen. All right, now let's see how we go here. So what we have here is we have time, and on the vertical axis we have the ATP, which is in the cell. So as I've said, we have this ATP energy challenge because the cell is clogged with calcium, and those poor mitochondria cannot function, and they're trying to clear out all of this calcium, but they can't because they're impaired, and so we've got this bad situation of an energy challenge. And so what we get is, in a concussion, we have an electrical storm. So we go from when we get hit, and you can think of that. So if you watch a footy game or a boxing game, or you see someone get concussed, they get hit, and what do after they get hit? They stagger, or they get knocked down, and then they get to their feet, and then they're okay. And it's a very classical stereotypical thing that most people can relate to. But what happens after that is, for the reason I just said, is we start to get a decline in the ATP in the brain. And this keeps going over several days. And after, if we just sort of draw a color here, if we just sort of draw a little line down like that, and after about 3 or 4 days, it reaches its lowest point, and then it starts to come back up. And then after, it's often, it takes a while. It's often, if we just sort of drew a line down there, we're often looking at kind of 3 to 4 weeks before we get back to, sorry, my handwriting's really bad. Let's see if we can make that nicer. 3 to 4 weeks before ATP gets back to its normal level. Now, this is really significant, and this is why there's all of these changes in the AFL around concussion and compulsory time off, is that what we get is around here, people start feeling better. And so their symptoms feel better. And if they go back to sport and get another concussion there, what we get is we get another drop in ATP and energy. And so what this line here is this is cell death. All right, which obviously sounds rather ominous. And so if we can get, it's called second impact syndrome, if we get a second concussion before the first concussion has resolved up here, then we start another cycle like this, and it takes much longer. However, if we get full recovery and we get another concussion, we stay up here, and so we're fine. And so the big problem with sport at the moment, and all these precautions put in for concussion, is this second impact syndrome here. And so one of the key things with management of concussion, which is really rammed home these days, is someone has a concussion, they start feeling better, they go, yep, I'm right to go back. We have this mandatory in local sport, it's 3 weeks. If you have a concussion, you have to be out. In the AFL, they do baseline testing. They've got a lot more sophisticated methods of determining whether people have fully recovered. So they can get them back sometimes after a week. But sometimes they're a couple of weeks. But according to a lot of the research, it's 3 to 4 weeks before we have physiological recovery of the ATP back to normal. And once we get that, if you get another concussion, you'll be fine. And then you recover again, full recovery, 3 or 4 weeks, you get another concussion, you'll be fine. That's at least what we know from the literature at the moment. Multiple concussions are fine as long as you have that recovery time in between. If we get a second concussion before the recovery time, then we get this extended drawn out recovery, and we can potentially start getting cell death in there. And there have actually been 2 cases of actual people dying with a second recovery, so with a second concussion, who have had a concussion immediately before, and in the week after they've had another concussion, and they've actually unfortunately died. So it can be quite catastrophic. And I will just, if we sort of drew that in, that would be going long. And if we had another concussion here, then we're in real trouble. It's like an exponential. It takes longer and longer and longer. All right. So that's the big story in concussion at the moment with all these athletes and stuff, is that it's multiple concussions, but it's the poor management of the initial concussion that appears to be the big problem, not so much the multiple concussions. If the concussions are managed well, then we don't have a problem. All right, so just jump back to there. There's my graph to remind me to stick the graph in. All right, and this is just a quick study here, and these were people who didn't follow the instruction of their doctor, and they returned to work too quickly. Boxing, rugby, soccer. So symptom duration for the first concussion. So it's here the age, gender. Symptom duration 3 days, 4 days, 8 days, 7 days, 8 days, 5 days. Then they went and had a second concussion with only 10 days, 9 days, 18 days in between. Look at the symptom duration after the second concussion. Is it days? So 52 days, 59 days, 44 days, 35 days, 44, 33, up from like 3 to 52, 4 to 59, 8 to 44. So it's just a really nice study from 2012, which really shows the second impact syndrome and why it is so important to allow the brain to recover before getting the second concussion. All right, so obviously I've said this a lot, but take-home message. Patient symptoms recovery does not equal physiological recovery, and it takes 3 to 4 weeks. If there is a baseline test at the football club, they can sometimes get them, show that they're recovered in 1 to 2, as you'll see at an AFL level. Return to sport or any activity risking a second impact needs to be at least a 3-week recovery period, as we said. That second impact can have serious or catastrophic effects. And any subsequent concussions, this is important too. Any subsequent concussions which occur outside of this window likely have no long-term impact for the patient, which is not what you will get when you're reading the Herald Sun and they're going on about CTE and multiple concussions, because there's a lot of media hype around anything concussion related, and this kind of stuff is not particularly well explained. Alrighty, moving on. So this gentleman is saying, I had a concussion. Does that mean my brain's moved from the skull? Oh, it's the guy from before. Yeah, the answer, no, that doesn't. That's not the way we see it anymore. Alrighty, you always get whiplash when you get a concussion. True or false? What do you reckon? If I get a concussion, do I have to get a whiplash? Just pause to come to your own conclusion. The answer is it's probably yes. If we look at the force required to get a concussion, it's 70 to 100 Gs. So it's a round hook from a heavyweight boxer. Apparently the jab just falls short, but the round hook actually gets it up there. For a whiplash, you only need 4.5 Gs. So if you're getting 70 to 100 Gs to get a whiplash, you have strained your neck, because your neck is only straining at about 4.5. So a study in 2006 showed that 100% of concussed athletes showed evidence of whiplash. And it's the most logical thing in the world. But as an osteopath, this is really significant, because neck injury has almost identical symptoms to post-concussion symptoms. So the question is, do they have concussion symptoms or do they have neck symptoms? And what we find a lot of the time is symptoms that are put down to concussion are actually coming from the neck, and we treat the neck and we have enormous resolution of the concussion symptoms. As an osteopath, we So there is some post-training that can be done in the cranial area. So we're looking at the myofascia, particularly it seems to get tight around the sutures for whatever mechanical reason. But that treating that area, if there is a concussion, if there is a trauma to that area, we tend to find that there is tension in that area, and that tension can affect the upper neck. So that's from the upper neck, from the top down. And we also look at it from the other way. If there is a blow, there's often a whiplash, and the strain can come all the way down the spine. So we want to be looking at that upper neck from the bottom up as well. So whilst the concept of treating the neck sounds quite simple, we also need to look at tension above and below. And that's something that at our clinic here we're very big on, and we do find that there are cases where treating the neck locally doesn't get much improvement. But if you treat, for example, if there has been a big accident or a car accident or something, and we treat from the lower back up into the neck, we start getting much better improvements. Or if we treat the head down into the neck, we get improvements where just treating the neck locally doesn't. Is there any evidence for us? This is just a quick study. How are we going for time? Okay, getting there. And this one had the osteopathic approach that I just described, where we're using cranial techniques as well as that whole body examination. And this was done on the SCAT5, which is a migraine diagnostic. And after one treatment, we had a 17-point reduction in symptom severity with the osteopathy and the cranial treatment, as opposed to just purely migraine education, only had a 4-point reduction. So it's a small study, but there's been a lot more on necks, and the neck is very clear cut. There's a lot of studies on that, but I just wanted to throw in some stuff with kind of this other aspect that we really find to be, clinically we've found this to be extremely helpful in a lot of cases. And just another study, there was a follow-up study done here, and they did it with a slightly different testing. And once again, they did 2 sessions, and they tested visual memory and reaction time, so a more objective measure rather than symptoms. And the visual memory showed a very large improvement with the osteo treatments compared to the concussion education, and reaction time also showed an improvement compared to the concussion education with the osteopathic treatment. So just a couple of studies there just to just show a bit of evidence. Alrighty, so we've got a concussion and we've treated the neck. There's a couple of other really key elements that have a lot of evidence behind them to show that they really accelerate concussion recovery. And one of them is exercise. And we'll get to this a little bit later, but the sooner we can bring in exercise, the better. So Buffalo treadmill test, and that's a picture of one of our treatment rooms, is we actually bought a treadmill for the clinic purely for this reason. And if you can find people's threshold for where they're getting symptoms after a concussion when they exercise, you can get them to exercise at about roughly 80% of where they're getting symptoms, and that can dramatically speed, well, depending on the case, can really speed up the recovery. What we know is that pure rest is not helpful for recovery, and correctly administered exercise can be extremely beneficial. So the treadmill test gives us a way to not exacerbate the patient. It finds a threshold which is safe, and we can get the exercise in, and the exercise is really beneficial for recovery. And I haven't got any studies up for that, but if anyone wants any, just let me know and I'll find you a stack. Vestibular rehabilitation is another one which has a lot of evidence to show that it significantly helps recovery. And it's basically, from my perspective, if we've got any musculoskeletal problem, we can have an exercise approach, or we can have a manual therapy approach. And this is the same with concussion. I've mentioned a manual therapy approach looking at the neck, and the vestibular rehabilitation gives us a way, through the eyes and the middle ear, gives us a way to actually kind of exercise into the brain and help recovery. And the basic gist of it is we're getting the patient to, turn their head or turn their body and just try and irritate the nervous system and see if we can create symptoms. And as soon as we create symptoms, we basically use that exercise to get the patient to do that exercise to try and work into that and increase their threshold. And there's a lot of vestibular rehabilitation stuff has come out in recent years, and that's certainly a box that that should, well, from an evidence-based perspective, should be being ticked. Diet, there's a lot of evidence around diet as well. We would tick this off with the GP as well, because with all supplements we want to make sure that there's no medication interfering with that. Anti-inflammatory diet, once again, there's a lot of evidence that anti-inflammatory diets, whether it's a acute or a chronic situation, can be really beneficial. All right, and so we've just got this guy here saying, when can I get back to work or play sport? Which is basically the bottom line that we're getting at here is how do we get these people to recover faster? All right, and I'm not going to read this all word for word, but this is the complete concussions protocol for returning to school or returning to work or returning to sport. And as you can see, returning to sport is more complex, and returning to just school or work. Now, the big one here, and if I'd done this properly, I would have put a nice big red circle around this first one, is that after a concussion, we recommend rest for 2 to 3 days maximum. So a lot of people have come in here and they've had a healthcare professional to say, hey, just go home and rest. But we want to try and get exercise in as soon as possible, according to all evidence. Did I put a study? No, I didn't do a study for that one. But once again, there's a lot of evidence around this. And so what we want to be saying is for the first 2 to 3 days, take it easy, but don't lie in bed all day. You can do you can do a little bit of screen time as long as it doesn't hurt, but just not too much. Very minimal screen time for the first couple of days, and then after that first couple of days, then we want to encourage working from home.
One of Molly's friends.
And so it's the first 2 to 3 days. We have we have rest, and as soon as that first 2 to 3 days is up, then we want to get people back into it. Then we go to half days of school, full days of school, 24 hours of each one. If we have a relapse or an exacerbation of symptoms, we regress. In sport, we bring in our treadmill test. We get them exercising. As it says here, 5 to 7 days, we've got them back exercising. None of this, don't do anything for 2 weeks. We're trying to get them moving as quickly as possible. And once again, for medical clearance, we want to try and, we don't just want rest, we want to be trying to bring the symptoms on, because as we've already mentioned, if someone's at rest, they can have no symptoms. So what they do at sporting clubs, and we have ways of doing this here as well, is that we try and bring on symptoms and see if under exertion they get symptoms or not. And so that's basically the difference for sport, is we kind of push them a little bit harder and we try and bring on symptoms. And if they're clear when we try and bring on symptoms, then we can look at full practice and getting back to sport. But we kind of want to push them a little bit harder and make sure that even after this this kind of like 3-week period, it's like, just check, are they still getting symptoms, because we want to get that full physiological recovery as much as possible. Driving, I just threw this in here just because I thought it'd be interesting. So the patient says, when can I drive? The guidelines from complete concussions: no driving for the first 2 days, and then short range driving with a passenger, so that obviously the passenger can take over if needs be. Then longer range driving with highways and cities, so more intense with a passenger. Then short range without a passenger, longer range without a passenger. So graduated return to driving. It's not just a black and white kind of, it's been a week, you can get back in the car. All right, so we're up top now, so we'll get through this really quickly. This lady's saying, I had a concussion 6 months ago and I've been having symptoms ever since. What should I do? So we're just looking at longer term recoveries, and basically it's the same stuff. It's the same stuff. We want to look at the neck. We want to look at potentially buffalo treadmill test. We want to see where their exercise bringing on symptoms, get them exercising as much as possible, vestibular rehab. Just a case study here. I had a guy who literally was walking along at night and fell down a manhole and landed on his chin. which is pretty unfortunate. Had an enormous amount of tension up through his head and his jaw, and he'd had some massage and stuff locally on his neck. It didn't really help, and he came in here after it was a long time. It was 9 months, 12 months or something. And very much by looking at that cranial area, the jaw, the upper neck, that tension around the head, we're able to get him symptom free. It did take quite a few months to get him there. And just contrast it to someone who came in just a little while back. He was a AFLW player, and she'd had a concussion, and we just did the protocol. We just said much quicker recovery, but once again we did some cranial stuff, and that once again immediately got quite an improvement. But anyway, the bottom line is that the acute and chronic recovery, we're looking at similar stuff, different durations, but it's kind of the same thing. Alrighty, and we'll go through this quickly. This guy's saying, I got knocked out for 2 minutes when I was concussed. Will it take longer to recover because my concussion was so severe? I put this in there. The answer is no. Loss of consciousness and amnesia have no correlation to recovery time. So I put this in here because there was, at one point in time, there was a concussion grading system, and it's not used anymore. So if someone comes in, they say, oh, I've got a grade 1 concussion or a grade 2 concussion. They've either found something on the internet, which is really, really old, or someone was trained kind of in that, I think it's around sort of early 2000s kind of era when this kind of came into play and just hasn't updated. So basically the grading concussion is based on loss of consciousness and periods of time and stuff, but it's since been found that it has no correlation to recovery time. Factors that do have an influence on recovery time are the symptom severity after the concussion, being female, which we don't know why. It could be hormones, it could be weaker next week, we don't know why, but it's easier to get concussed if you're female, and recovery will tend to be longer if you are female. Pre-existing mental health issues, depression, definitely if you have someone with mental health issues and depression, definitely, and we've seen this a lot, much more likely to have a longer recovery, and you see that with chronic pain as well, and not just concussion. And if the person has an existing neck or shoulder injury and they get a concussion, longer recovery, which makes a lot of sense based on what we've just said. Time frame from injury to presentation. Oh yes, I'll put this in red for a reason. And I probably should have a slide for this. The biggest factor for speedy recovery for concussion has found to be how quickly they see someone who is trained in treating concussion, whether it be vestibular rehab or neck treatment. That was the biggest factor to reducing how long the concussion lasted for, which just shows how a multidisciplinary approach is really essential for concussion, because obviously we need GP management, but also treatment of the neck is really important, however it's done, and the vestibular rehab is really useful, and of course the exercises as well. I'm just sort of thinking. So person A, just to use your brain. Person A, use it unconscious for 2 minutes, can't remember it, and he's got mild headache, not much dizziness, not much light sensitivity, sound sensitivity. So he's not feeling too bad. Person B, she's not knocked out and she can remember it, but she's got severe headache, she's got significant dizziness, light sensitivity. So she's got a high amount of symptoms after the recovery. Which one has the highest risk of recovery? It is obviously person B. It is not. It has nothing to do with the fact that he was knocked out. Knocked out has nothing to do with recovery time. Not being able to remember the incident, amnesia at the time. If you have amnesia afterwards, different story. If you can't remember what you just did, that's completely different. But if you can't remember what happened at the accident, you have amnesia from the time of the accident, doesn't make any difference to your recovery. Being female, headache, high factors here will indicate that you are, and obviously you're not going to say this to them because then you're going to put it in the head, but just a little point of interest that those are the factors that will actually give you a longer recovery. So gone a little bit over the 30 minutes there, but That's a quick summary. If you're in the area, if you have any concussion patients you'd like help with, that's our address. So I've got my email address there. If you have any questions specifically, obviously we'll keep you in the loop, and we want to send them back to you as much as possible. And just quickly, if there was any questions, just jump in now. All
Good
silence.
question, Cameron. What other mental health issues is like also is related to concussion other than depression, like with
As
recovery?
in prolonged recovery.
Yeah.
Um, Off the top of my head, I'd say generally speaking, anything where we have, any anxiety, depression, pre-existing condition like in that realm,
Mm. Yep.
we're likely to have a more drawn out recovery. And
Okay.
as I said,
Yep.
I say that with a fair bit of confidence because that's exactly the same with chronic pain.
Mm.
And we've done obviously a fair bit of training with migraines and stuff with chronic pain. So, we had someone in recently, and she she suffered from a lot of period pain, which is a bit of a chronic pain kind of you know situation. And she was really stressed at work, and she was playing futsal, and she got smacked in the head and concussed, and she took months to recover. Um, and we got her there eventually, but yeah, it was a very concussion. Obviously, she was definitely not knocked out. She could remember it and everything, but yeah, when we get these other factors coming in, that seems to be the people who get the really drawn out recoveries that are harder to get back to where they were.
Yeah. Oh, okay. Thank you for answering that. That was really good. Let me just check the chat if there's anything else. Um, oh, someone said that very interesting and lots of new info for you. Do you accept EPC referrals as well, Cameron?
Absolutely, yeah, yeah. I mean, there's usually a gap, but yeah, absolutely. We yeah, all day long we're processing APCs. So yeah, absolutely.
Perfect. Any other questions for anyone else?